Welcome to the She Found Motherhood podcast. Today we have Dr. Ginevra Mills talking to us about what does the process of getting worked up and investigated for infertility look like when you've been referred to an infertility specialist? This is the third in a three-part series all around infertility. So if you haven't listened to the first two, head on over and listen to this after you listen to this podcast. So right after this quick reminder, we will get into the podcast with Dr. Ginevra Mills from Olive Fertility.
Welcome to the She Found Motherhood podcast. We are doctors Sarah and Alicia, maternity physicians and moms who have been through it all. We want to empower you with knowledge so you can have the best pregnancy, birth, and postpartum experience you can.
She Found Health and She Found Motherhood is meant for general medical information only. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. This information does not apply to every situation. If you have questions or if you've received different advice, please contact your healthcare provider. Always seek the advice of your physician or another qualified health provider with any questions you may have regarding a medical condition. The views expressed by She Found Health and She Found Motherhood and our guests are not representative of any of the institutions with which we are affiliated. Some of our podcast episodes are sponsored so that we can keep getting great info out there to you, our listeners. We only partner with companies that we truly believe in. Some of our links and suggestions may be affiliates, and we would appreciate you using them to help fund this important work. Now let's get to it.
Welcome back, everybody. Today is our third podcast in a three-part series on infertility, fertility, and infertility. And Dr. Ginevra Mills from Olive Fertility here in Victoria is joining us again. Thank you so much for joining us. She's an obstetrician gynecologist with a specialty in reproductive endocrinology and infertility, and a special interest in PCOS and lifelong health. And she's got 3 young kiddos and likes running outside. And is really quite lovely, actually, I've discovered through our journey together. So today we're going to talk a little bit about, so you've now referred to a fertility specialist. What happens now? What does it look like? So why don't you quickly tell us a little bit more about yourself, anything I missed, and then we'll get into the podcast.
No, thank you again. I've really enjoyed being part of this little mini series on fertility and infertility. And I've also really enjoyed getting to know you through this process. I think you pretty much said most of what has to be said. I'm pretty new to Victoria and the island. We just moved here in September when my kids started school, and I'm really enjoying being out here. I've never lived out here before, and I am looking forward to starting trail running. I put it off with all the rain and the mud and trying to find the right places to go, but it's on my list for the spring. Yeah, thanks so
Great.
much.
I'll do that with you. I'm trying to get into it myself, although you're probably much fitter than I am. Awesome. Okay, so we're going to talk a little bit about, so you've seen your primary care provider, be that your family doctor or your nurse practitioner, or you've seen a naturopath who suggested maybe you should get a referral. And so you've talked to a walk-in clinic, whomever, however you've accessed care. And the recommendation has been to have you seen by a fertility specialist, such as Dr. Mills. So what does that process look like?
Yeah. So the most important thing to know is it doesn't matter. So unfortunately, because of rules, MSP rules, you need to get a referral from generally a physician. So if you don't have a primary care physician who can refer you, you can go to a walk-in clinic or even one of the virtual health platforms, and you can get a referral from them. And whether you've been referred from a primary care physician who knows lots about you, or you've been referred by some doctor in a walk-in clinic, someone who's ever met you, it really doesn't make a difference. We're going to get to where we need to get in the end. So don't feel dissuaded if you're being referred from someone who doesn't know anything about you or your history. And so that sort of brings me to what happens at the initial consultation. In the initial consultation, you can expect to speak to your fertility specialist for anywhere between 30 to 45 minutes. And during that time, we're going to mostly go over your histories. We're going to talk about your medical history, if you've had surgeries before, if you've happened to be pregnant in the past or not, if your partner has been pregnant or has fathered children in another relationship. And we'll go over your medications, all those types of things. Oftentimes, if you've had a family physician or a primary care provider refer you, they might send some of that information to us. But we always really like to go over it because we just want to make sure we don't miss something. And sometimes different physicians pick up on different things that they may not know is important or not important. Before COVID, there would also be a physical exam. Often this takes place mostly in our clinic, it involves a transvaginal ultrasound. So that will get done eventually, even if it's not in your initial consultation. And going over your height, your weight, and there's not, and sometimes your thyroid and everything like that. During COVID, ongoing now, we still do these consultations virtually. So we will ask your height and your weight, and we like to do it all. We do them by video, so we can at least see you. But mostly it's talking about your history. I had alluded to that transvaginal ultrasound. So often we will have you come in separately from the initial consultation to do that transvaginal ultrasound. And a lot of people say to me, but I had an ultrasound. My family doctor ordered an ultrasound. I've already had a pelvic ultrasound before. This pelvic ultrasound is special. And it's special because I do it. Not just me, but a reproductive endocrinologist does that. And we're looking specifically at your ovaries. We're counting the follicles on your ovaries, and we're looking to see if there's any types of cysts, where those cysts are located, if they're in our way, like if we need to do IVF, for example, can we get around those cysts? And we also look at your uterus because that's important too. Is there a problem with your uterus? Are there problems with your fallopian tubes that could potentially be seen on ultrasound? And so that we're looking at them from a perspective of, if I needed to do IVF and I want to get this person pregnant, is there something that I need to know? Versus a general pelvic ultrasound who's done by a technician and read by a radiologist who looks at all types of ultrasounds. They don't really care that much about pregnancy. They're sort of the all-comers of that. So that's why this pelvic ultrasound is really important.
Yeah, and I think it's also important to note a couple of things from that. I'm just going to interrupt you. Is part
Mhm.
of your history is, and we've talked about this in the last podcast, is asking a sexual history. And so that's a history of sexually transmitted diseases. And this is really important information to know, both from you and your partner, because it can, in fact, impact your fertility. And so I think a lot of people feel these types of topics are maybe not something they want to be open about, or they don't want to be open about in front of their partner, or whatever it is, but it's actually a very important part of your history for your specialist to know, because it certainly can impact how your body kind of functions in terms of kind of that fertility perspective. So I just wanted to make sure that we chatted a little bit about that, and the
Right.
fact that you ask the questions that are actually really pertinent to the medicine that you're practicing, and in no way are you judging people, or are you assuming things. We just ask the same questions of everybody. And so sometimes I think that that's really important to kind of just say and be
Yes.
out there.
And I want to just add to that a little bit. You bring up a really important point, and this is about not just sexual history, sexual practices, but also something that comes up a lot is people, they're trying to get pregnant now, but maybe a while ago, they were in a different relationship. They were in a different stage in their life, and they had gotten pregnant, and for whatever reason, ended that pregnancy. A lot of people have guilt about that. A lot of people haven't necessarily disclosed that to their partner, and that's okay. And if you have something that has happened in the past that you haven't shared with your partner yet, it's really important that as your specialists know that. But that's your business, and I'm not going to get in between you and your partner. And if you tell us ahead of time, so you'll have an intake call with what we call our patient care coordinator. Let them know, I had a termination in the past, but my partner doesn't know about it. So can you let Dr. Mills or Dr. Graham, who's my colleague, or really any fertility center you go to will have this in place, to just say, I have this thing that my partner doesn't really know about, and I don't want them to know. And that's perfectly fine. And your secret is safe with us. So that's just a little side note. So thanks for bringing that up.
Yeah, it happens in pregnancy care as well. So oftentimes people have had whatever happened in the past and they don't want their partners to know about it. And so we just make a note on the chart so that everybody's aware, because it's important information for us, but it's not something that we need to talk about in front of their partner or their mother-in-law or whomever.
Exactly.
There's still that doctor-patient confidentiality. So yeah, I think that's important just to mention. Okay, so they've done their initial consult with you and they've had their transvaginal ultrasound, which is super specialized ultrasound looking for very specific things that our general pelvic ultrasounds aren't looking for. What is next?
And then there's some blood tests that we do. And we primarily are doing these blood tests to look at our ovarian reserve. And the ovarian reserve, the biggest blood test we look for is your anti-Müllerian hormone, which we talked about in a previous podcast. And we also will test your thyroid. Those are the baseline. If your family physician or your primary care provider has done other blood work and they've sent that along, we'll look at that, and that can sometimes be helpful as well. If you are presenting with polycystic ovary syndrome, for example, or you're presenting with another obvious cause of ovulatory dysfunction, there's other specific blood tests that we'll order, and you'll get a requisition for all of those. But we're trying to choose wisely, so we don't order these tests on everybody. We order them when they're indicated. And then for the partner with sperm, there's a sperm test that has to happen.
Awesome. So you get all of that information back, and obviously, depending on the results, make some recommendations or optimize things. Now,
Yeah.
if you do recognize on your super fancy special ultrasound that there is something going on with the kind of the tubes or the ovary, are there any kind of, I guess that would be more into the treatment kind of zone?
I sort of forgot to talk about one other test that we often send the partner with the uterus for is a test to check to make sure the tubes are open. So fallopian tubes, unless there's something drastically wrong with them, we can't actually see fallopian tubes on an ultrasound. So we send away for a special test. This is called a hysterosalpingogram. They're a really nasty test, if I'm being completely honest. It's an X-ray, and we put radiopaque dye through the uterus and fallopian tubes, and this is dye that can be seen on an X-ray. And we watch to see if it comes out of the ends of your tubes. It's a little bit of an antiquated test, but it works really well and it does the job we want it to do. So we'll often send patients for this, and you'll get the requisition either as part of your intake or maybe even after your initial consult. It just really depends on when your intake happens, if the test has been done in the past, and how long it takes for you to get your appointment. Sometimes you can have your blood work and the hysterosalpingogram done even before you end up having your consultation with the physician, just depending on how long the waiting list is.
And sometimes,
So
correct me if I'm wrong,
no,
that can actually, if there's a little tiny little blockage in one of your tubes, that can pop it right out and help to solve the
yes.
problems right there.
Yeah, so the rules when you're booking a hysterosalpingogram, they're a little bit tricky to book, but the reason they book them that way is they only want you to do it in the first half of your menstrual cycle, so that first of all, it doesn't interfere with you ovulating and potentially getting pregnant that month. But that dye, it flushes out your tubes. So if there's anything in the way, I think there's even this hypothesis that it stimulates like the little cilia inside the fallopian tubes, and they get all excited and they're like, oh, here we go, let's make some babies and move them, let's make some embryos and move them into the uterus. People are actually found there's a higher rate of pregnancy usually in the month or two after a hysterosalpingogram is done. Yes, you can try to get pregnant the month you do your HSG,
Yes, and it
and you
might
should.
help you. Those cilia, they get all excited.
Is this pain I'm feeling in my pelvis normal? Should I do genetic testing for chromosomal differences in my baby? Is it safe to go to the dentist while I'm pregnant? Doctors and maternity specialists Sarah and Alicia are here to empower you with even more knowledge so you can have the best pregnancy, birth, and postpartum experience you can. Presenting the Pregnancy to Parenthood podcast, a new series of informative episodes geared week by week toward whatever trimester of pregnancy you're in. Tune in weekly, following along relevant topics as you move through pregnancy, or just binge listen and come back to the episodes you found most helpful. Access the full series for a full 2 years and listen to it on your own time. To learn more, go to www.shefoundhealth.ca or click the link below.
Okay, so what else? What that happens next? So they've had all of this testing, they've had everything looked at, and then presumably you take all of that information and if you can figure out what's going on.
Exactly. So we put all of that together. And so those tests, so the ultrasound, the hysterosalpingogram, the semen analysis, and the blood test, we can usually put all of that in, and your history, of course. 90% of medicine is taking a good history. So you get all of that information, you put it together, and we come up with a cause of infertility. And as I talked about in our previous podcast, about 85 to 90% of the time, we find an explanation. And it's maybe there's a problem with the egg being released, maybe there's a blockage, maybe there's a nail problem, but sometimes we don't find a cause. And then once you have the initial consultation and have all these tests done, you have a follow-up appointment. And in that follow-up appointment, we go over all of the results. And that's where we're really going to talk about the treatment options that are available. And treatment options are actually quite specific. We have a lot of patients who come in and say, I had a friend who went to a fertility clinic and they did this treatment and we want to do that treatment. And that treatment might not be available to you because it really just depends on what your friend's causes for infertility were and what your causes are for infertility. And so we have a wide range of options, ranging from doing nothing and saying, okay, we haven't found an issue. And saying some people just are happy with that. They're like, okay, we don't have a problem right now. We're just going to keep trying. And we can go all the way up to the most invasive and unfortunately most expensive options, which in general includes IVF.
Awesome. So, question for you. Oftentimes people want to know, what can I be doing in the meantime? What can I be doing while I'm waiting for the referral or waiting for all of this workup? Are there any kind of lifestyle modifications that I can be making to give me a better chance of either getting pregnant on my own or if I need support to get pregnant, having a healthy pregnancy following that. So I know you have a special interest in lifestyle health. So what are your general recommendations for the population?
Yeah. So in people with PCOS who aren't ovulating, I often will have a good talk about dietary management of PCOS, specifically insulin. This again could be a whole other podcast, so I'll just try to be a little bit quick. But PCOS is related to insulin resistance. And when your whole body becomes insulin resistant, your ovaries don't. And so your insulin gets really high, your ovaries are swimming in too much insulin, and it affects the way the follicles work. So I often talk to patients about modifying their dietary lifestyle to try and reduce the amount of insulin that they have floating around in their bodies. And most generally, I recommend lower processed carbohydrates and also lower carbohydrate in general. I always say to patients, you don't have to be keto because people hear low carb, they think keto. That's not what I'm saying, but just really thinking about where you're getting your nutrients from and what that is. And so it's not necessarily about weight. A lot of people with PCOS are overweight, and then they think that they have to lose weight in order to get pregnant and to ovulate again. But it's not so much about the weight. It's all about the insulin resistance and the insulin that's in your body. The weight loss has a really great side effect. Weight in general, we have seen in studies that people who carry extra weight, especially if they fall into that obese category, they have lower implantation rates when we do embryo transfers. And so we know that there's some relationship between having excess weight and pregnancy success. But we also know that stress has some role in how infertility manifests. And so you really just need to find a good place where you're comfortable. If you're carrying some extra weight and thinking about modifying your lifestyle to lose that weight causes an extreme amount of anxiety and stress for you, you just need to find it. So you just need to do what you can do: stress and moderation, lifestyle and moderation. Of course, being anything that's good for your overall body and your overall health is obviously going to be good for getting pregnant. But I also really don't like to put a lot of extra weight on people's shoulders and be like, sorry, you need to lose weight. I'll lose weight, come back and see me in 6 months. That's not my style. And I don't think that should be anybody's style. But since you asked, I'll answer. There's also the obvious. If you smoke, you really should try to quit, if not at least cut back on smoking. Recreational drugs, illegal recreational drugs are often recommended to stop. Marijuana, CBD oil, that kind of stuff. We do know that it can impede the function of the fallopian tubes, and it can definitely decrease sperm motility. So if you're using those in excess, I would definitely, if you can't cut them out completely, significantly reduce them. And alcohol intake, again, if it's good for your overall health, it'll be good for your fertility.
To decrease it. Yeah. Okay. Awesome. So the general healthy lifestyle living recommendations, probably some good sleep in there as well. Anything that cuts down on your stress.
And one thing that I have a lot of patients come to me with is timing sex properly. So people are really busy. They can be stressed out, have different work schedules, whatever. And timing sex, if you're timing sex to ovulation, you need to be reliably predicting your ovulation. And really the only way to reliably predict your ovulation is to use ovulation predictor kits. Using an app, if you want to use an app to track your period, when am I expecting my period? That's perfect. But using an app to tell you when you're going to ovulate is not very accurate because everybody ovulates differently. And so you need to be doing ovulation predictor kits. If you do ovulation predictor kits for a couple months and you're saying, okay, I'm always ovulating around the same time every month, you can ditch the ovulation kits and now you're reliable. But some people aren't that reliable. And so when I hear people say, yeah, we never have sex except when I'm ovulating. And then I say, well, how do you know you're ovulating? Oh, I'm using an app. Then that's a bit of a red flag. The biggest lifestyle thing is if you're timing your sex, you need to time it. You need to do it properly. And that's
that egg needs to be fertilized within 24 hours of release, and sperm can last up to 5 days, correct? So you want to time it so that there's sperm in your genital area, in your uterus, ready to meet that egg once it comes down those tubes, right?
Yeah, that's absolutely right. So that your fertility window is calculated, even when you use those apps, it shows you 6 days that you're fertile. That's the 5 days before you ovulate and the day you ovulate. If you are ovulating on day 14, you should start having sex on day 9.
Yeah, hedge your bets, hey? Awesome. Okay, thank you. I know that was a lot to cover, and there's no same answer for different people. So thank you for giving us the general idea of what people can expect if they're going to see a fertility specialist. And obviously we didn't get too into treatment, but that's because it's very much individualized on kind of a case-by-case basis. So hard to generalize those things. Thanks so much for doing this series with us. It was really great. If people want to find you, you work at Olive Fertility in the Victoria office. I'm excited to come see your new office. Looks fancy. And they can find you on Instagram at
dr.ginevra.mills.
Perfect. And we will tag that below. And that's the third time I've asked you and I could never remember. So I will now remember.
No problem. Thank you so much. I had a really great time making this series with you, and I look forward to some collaborations and also having you come and check out our new clinic.
Love it. Thank you.
Thanks for listening. Make sure to check out our website at www.shefoundhealth.ca and to sign up for our community for weekly bump blasts. Make sure to check us out on Instagram or Facebook at she.found.motherhood and head on over to your favorite podcast app and leave a review and a 5-star rating. If you enjoyed this podcast, take a pic of yourself listening to it and share it on social. Make sure to tag us on it so we know to keep making them.